My name is Habil Otanga from the University of Nairobi, and my co-presenter in this progress report shall be Dr. Semoju from Makerere University. We are doing a scoping study titled Exploring the Use and Efficacy of Peer Support and Social Networking in the Management of Diabetes in Kenya and Uganda. And the theme of our proposal was prevention. But as I already said, it is a progress report. This team is made up of 4 early career researchers. We have me from the University of Nairobi. We have Dr. Semoju from Makerere. We have Dr. Aungo from the University of Nairobi. And we have Lynn Mwaniki from the University of Nairobi. My co-presenter shall pick up in the next slide, but I just want to finish by saying that we are a team from 2 universities, 2 ARUA universities, the University of Nairobi and Makerere University in Uganda. And we created a research group, and it's our hope that we'll continue collaborating on similar research interests in the future, beyond the scoping study that we are doing. And just a point of interest is that Dr. Semoju and I met during the Partnerships for Africa's Next Generation of Academics. We had a fellowship in Cape Town, South Africa in 2018, and that's where we met. So this is a strong research group. Brian, I would prefer that you pick on, maybe I can take up the slides for you, Dr. Semoju.
Thank you, Habil. If you prefer to continue with the presentation, that is fine by me. I will come in whenever it is necessary.
Okay, thank you very much. Okay. So our scoping study is essentially a desk review of literature, and we are also doing in-depth interviews on diabetes peer support and social networking mechanisms. So what we're looking at is how is social support used and how efficacious is social support? And then 2, how are social networks used and how efficacious are social networks in diabetes self-management? At the end of the study, we intend to have a journal article in a peer-reviewed journal. We also intend to have a proposal for a larger study, especially on identified interventions and issues that will be coming out of this study. And then finally, we also look forward to identify funders for that phase 2 of the study. And one of the things it will help is to maintain our group. So the objectives of this scoping study, we want to look at the extent of use of peer support and the extent of use of social networking in diabetes self-management. 2, we want to look at key mechanisms and structures of peer support. 3, we are looking at determinants of adoption of peer support and social networking. And then we are also looking at how efficacious is peer support and how efficacious is social networking. Then finally, we want to come up with a model that can put together several models for better diabetes self-management. We have done a number of things up to this point in time. We have done our desk review. Of course, that is after all the necessary approvals were sought and received from the ethical approval authorities. And we have done a desk review. The scope is on the use and efficacy of peer support and social networks. Since we live in a space, and the space is sub-Saharan Africa, we have toured sub-Saharan Africa, but settled on Kenya and Uganda because that is our location. We have selected the time span all peer-reviewed journals all peer-reviewed journal articles between the year 2000 and 2021 that describe the use and efficacy of peer support and social networks. We have also reviewed a bit of gray literature. This has to do with websites like for the World Health Organization, websites like for PS for Progress, among others. We have also looked at country policies on diabetes peer support mechanisms, specifically the policies in Kenya and the policies in Uganda. We are going to the next stage of doing in-depth interviews. We have specific targets. We will be looking at focal persons in health policies. Then we will also be looking at people directly involved in diabetes support and care, specifically in the primary healthcare. We'll be looking at peer leaders. So we have identified primary care centers where peer groups are being used for diabetes self-management. So we will be talking to the peer leaders. And then we will also be talking to people who live with diabetes about their own experiences and how networks and peer support is helping them to self-manage diabetes. So far, as I've already said, we have done a database search. We have looked at a number of databases from PubMed to Science Direct, among others. We have selected data. We have charted data. We have reviewed abstracts and full articles. And I just want to hasten to say that when you're on the outside looking in, you always think that there's so much that has been done in a specific area until you get into that area and then you discover that not so much has been done in that direction. That is what we have been encountering. So we've had so many abstracts, but at the end of the day, we've not had so many full articles, specifically in Kenya and in Uganda. So we've done some partial analysis, and we have used data from Sub-Saharan Africa for comparison. We have also made initial contact with key informants, such that we should be looking at them, we should be talking to them, most likely the week starting Monday. A number of things have emerged. Since a scoping study is supposed to tell us what has been done and what are the gaps, we are coming up with a number of observations. One of them is what models are used. And we have found that most models are facility-based. Therefore, most models are directive. And therefore, there is somebody who is in charge of a group, in charge of education, and then this person is giving education to other people. So most of them are professional-led, either by nurses, by dietitians, by nutritionists, and the rest. So those ones are professional-led, and they provide diabetes self-management education, and they also provide diabetes self-management support. A few are led by lay professionals. We are talking about peer supporters. They have a lot of names. In Kenya, they are called community health volunteers. In other countries, they are called community health workers. In Uganda, they are called village health teams. They are also called peer educators. So this is another type of provision of peer support. So basically, there are two types. Either it's directive, which is facility-based, or it's non-directive, this one that is led by lay professionals. But we're also discovering that we have innovative approaches, including mobile health, the mHealth, and we also have an interesting approach called microfinance that is being teamed up with group medical visits. So these two models for Kenya and for Uganda are in the recent past. They have not been around for too long. The use of mobile health definitely because technology is just starting to get entrenched within our populations, and that's why we are starting to use mobile health. And then we have microfinance, and then teaming up with group medical visits. We are finding out that in terms of social networks, we have two types of networks. either the network is proximal or the network is distal. When it's proximal, we're talking about family and friends coming together to support. But we also have vertical structures. These ones are the ones that you're referring to as distal networks. Fortunately, proximal networks, that's friends and family, can provide very good social support. But they can also be very unhelpful because we are finding that friends and family, that is proximal networks, are responsible for the use of ethnomedicine, what is also being referred to as medical pluralism. People are mixing medicine from the hospital and then medicine from traditional healers. Proximal networks are also responsible for stigma, especially since they do not have enough resources to deal with diabetes self-management within the network itself. So stigma now arises. The most important thing to note is that in proximal networks, what hampers their support is poverty. And therefore, the innovative approaches that are coming up are trying to get into this gap, to fill this gap, such that people are helped to deal with diabetes even within poverty. One more thing we have found out is that community health workers or village health teams, or whichever name they are called in whatever country, are supposed to be the connection between proximal networks and distal networks. But that's where the argument ends. Why? Because community health workers are not a good connector of proximal and distal networks, because the one question we need to answer is, how much should we train the community health worker? How much? Should they be as good as the professional health provider? Or are we thinking that by training them for 1 day up to 1 week, then they have enough capacity to deal with peer groups? So that is something that now hampers their ability to connect between proximal and distal networks. So they are not able to join the two. They are also not respected within communities. Then they are also not respected by healthcare providers, because healthcare providers in the formal system think that community health workers want to assert their duties. And then essentially, they also lack support. We are talking about support from the top, because as we already know, a community health worker is as good as the health system. Community health workers cannot operate in a weak health system. We cannot expect them to work very well in health systems that have a problem. So that is why community health workers are not very good connectors of the proximal and the distal networks. And therefore, as we talk about efficacy, we need to remember that that institution, that entity that we've given the responsibility to connect the proximal and the distal network is hampered by a lot of other things that I have already explained. Going to the distal networks, health service provision in many sub-Saharan countries, Kenya and Uganda included, have budget deficits in health provision. That has an implication for proximal networks. It means that family and friends have to dig deeper into their pockets to help in diabetes self-management. So the efficacy of proximal networks is now being affected by these budgetary cuts in the distal network. And so they are overburdened. The moment you overburden that network, then it has implications for stigma. It makes someone start looking like a burden. It makes the diabetes, the person living diabetes, become a burden to that network that they exist in. And because of that too, then the cheaper alternative is for these people to self-manage by using herbal medicine. That's what you're referring to as medical pluralism. And one very interesting thing we found out is that we have parallel networks. This is the network comprising traditional healers. traditional healers, and especially in Uganda, they prescribe, they make referrals, and interestingly, they make referrals to the formal healthcare system. They provide education. And there is a loop. There's a loop between them and the formal healthcare system in such a way that the formal healthcare system refers patients to them, and they also refer patients to the formal healthcare system. That's quite interesting. So we are finding that because of poor linkages between social networks, as we go on and complete our work, it is evident that the efficacy of our social networks will be low just because of poor linkages. And therefore, there is need to strengthen proximal social networks. How do we do that? Two ways. By using the innovative approaches that we are now using, the use of technology in mobile health, and then the use of microfinance coupled with group medical visits. And then a third way is to integrate the management of NCDs, diabetes included, into existing communicable disease structures. Like when we do screening, we can do screening of diabetes hand in hand with the screening of HIV, or hand in hand with any other communicable disease. Why? Because we have very good existing structures for communicable diseases, but we don't have very good existing structures for NCDs. Therefore, we can simply integrate the management of NCD into existing communicable diseases structures. So the next steps that are coming up very shortly, we need to have a workshop. We will be having a workshop, most likely online. We need to examine the issues that have been coming up from the desk review, and then prepare for the next stage called talking to our key informants. Then we shall be identifying themes for our journal article. Then we shall be discussing new interventions. Of course, from the review, we can see a lot of gaps, like the few that I talked about. This shall be discussed with a view of putting them together for phase 2 of that project. And then, of course, we shall go ahead and do in-depth interviews. The major challenge we have had is the delay in the letter of award. We got our letter mid-June, and we got funding in August. So we are really trying to make up for time. Thank you very much.